We're going to provide the agenda of what we're going to do today, and then we're going to, so here's the agenda. We're going to start off with what you thought about Dr. Trowen's presentation prior to this, and then after that, what we're going to do is I'm going to review the case study and the social work initial follow-up assessment with you guys. And then at that point, I'm going to turn this off, and we are going to separate each of you with one of us so we can talk about your scenario, because we're going to have a role play where you're going to discuss with Miss S and one of her siblings regarding a concern based on the follow-up assessment that the social worker provided for you. So at that point, because nobody will be in here, it'll be turned off. And then when we come back, we're going to do the role play, we're going to do the simulation, it'll be turned back on for that, and then we're going to have a debriefing to find out how you felt about it and where we could go from there. All right? So what we're going to initially start with, and Leilani, obviously you can take over, is how you felt about Dr. Trowen's presentation with regarding capacity, and if you feel like that may be helpful moving forward, as Dr. Trowen said, when you grow up.
And what questions might you have, or what thoughts occurred to you as well? So did you have any additional questions, thoughts, concepts about the topic in general that we could circle back and maybe answer for you now or bring back to you in another way?
No.
Okay.
We wanted Dr. Trowen to meet you virtually and meet the members of the team in OEN to demonstrate the medical support of this intervention that we're delivering across Western New York. And I know that Dr. Zimmerman, when we were there face-to-face in one of the previous sessions, verbalized a lot of concern about competency, and I thought it was important for Dr. Trowen to present that and bring some clarity to the issue of the role of a primary care provider in demonstrating their best judgment based on their clinical decision making, their best judgment overall of the patient. Does the patient have capacity to make their own decisions? Do they have no capacity to make their decisions? Or the third option that I don't know that Dr. Trowen mentioned was that further evaluation is necessary. And all you have to do is document that. Further evaluation of this person's capacity needs to be determined. That's one of the 9 domains of the GO 505 code, and that was Dr. Zimmerman's concern. Is she wasn't comfortable as a primary care person being somebody who would be able to address that, but it's within the scope of your primary care judgment that you're making it. So I thought that was really critical to get out there.
And when we're discussing capacity in a non-legal sense, some of the things that we're talking about is how are they functioning in daily life?
Correct.
What are their activities of daily living, and how much they're restricted with regards to that. So at that point, how much level of capacity from a functional standpoint would they be able to would that limit what you believe is their cognitive impairment to go forward?
Right.
So.
What about medical decision making, like the capacity to make their own decisions?
Yep. Actually, that is at the heart, because I think Dr. Zimmerman was saying, we're often called upon to make a determination whether this person is able to fully appreciate and understand their own needs, and in a situation of like potential skilled nursing placement, long-term care placement, I'm being asked to make that judgment. And so that is actually what the ICD-9 code is actually for. It is the rollout of several tools, Minicog, other assessment tools in a very step-by-step manner, which we have for you in the toolkit.
Okay.
And so it gives you more than one tool. And it gives you the time to have a separate visit to attend only to that issue. So if you screen, and on the mini-cog, there's a finding that there's some indication that there's a concern, there may be an issue here, what that allows you to do is to schedule a completely different visit, so that you have the time, and the reimbursement levels are good, to roll out this code. And there's a toolkit, there's a mini-cog, and there are several other readily used instruments. And your judgment as a clinician, there are options. There are options to which tool you would like to use. Some of them are very streamlined, rapid and quick, and others are more detailed, but certainly usable within the scope of yourself as a trained physician. And in many cases, or we or other colleagues could train some of your colleagues in the office, a nurse, a social worker. That is common standard and accepted practice, but certainly you would need to review them. And so you take all of those pieces together, all those domains, and one of the domains is your clinical judgment. It's only one part of it. Your clinical judgment on the severity of the impairment. You know, are they mildly impaired? Are they moderately impaired? Are they severely impaired? You are allowed to make a simple clinical judgment based on your observation, the history, whatever other information you need. And that's also what we're here for too. So if you get into a situation you're like, I just cannot come to an understanding. I see all the tools in front of me, but I've got conflicting information. But that code and all the tools within that code are designed to give you so that you know that you have gone through a breadth of assessment. You're not relying on one day, on one tool, on one type of assessment to make that judgment. So it is a toolkit for assessing cognition. And then at the end, the assumption is there, and to deliver that code, that there's not an assumption when you're assessing, but there is the time to, if there is an impairment indicated, to create a basic plan of care. And that plan of care could be very, very simple. It's call me in a week. It could be read this about cognitive impairment. It could be very simple, or it could be more complicated.
And as we go through this session that we're doing today, we might even consider, if there's a need, doing a whole dedicated session, videotaping it on implementation of the follow-up GO505 visit, and actually looking at the different instruments. See, they don't dictate which instrument you do for which instrument you select for each domain. It's totally up to you. But they're all validated, standardized instruments, and so that you could actually see the implementation and the rolling out of what a GO505 visit could look like.
Yeah.
That
So
might
we'll
be
give you the
helpful.
toolkit, you could take a look at it.
Right.
We could do a
We should
half-hour
probably
webinar.
consider doing that
Yeah, I think that's great.
for folks.
Excellent. Okay, wonderful. So,
All right.
That's great. So actually what we're going to do then, right, Mark, is we're going to get ready to role play the follow-up visit.
All right. So I know you guys, I sent it to Carrie. I'm not sure if you got it with regards to the case study and the social work initial assessment, follow-up assessment. But what I'm going to do is, just like I've done in the past with other training sessions, is I'm going to read it for you just so you guys have an idea. So then when we stop filming and we go into our separate areas, you already kind of have already have an idea of what's going on. So I know it sounds redundant because you're reading it at the same time, but I've always been one to say that while a person's reading it, it kind of sticks in your mind a little bit better. So I will start right now.
And Mark, sorry, before you do that, I'm so sorry, I just want to do one more thing with the flow to make sure on the video that it's clear. So Mark's going to give you the case study. This is very similar to the case study we did in our session with Linda and Mark on the screen, right? So we'll go through more detail. You'll find that out. And then the presumption then is you will then, for the follow-up visit, the patient will be coming back for a follow-up visit, you will have the benefit of a social work note to consider
Okay.
prior to the follow-up visit. So you're going to read the case study, and then we're going to read what's happening just before the follow-up visit. And then we're going to brainstorm and role play, how does that follow-up visit look?
All right, so let me put this down or else it's not gonna work. Sorry, Linda, I just cut your head off.
That's okay.
So, Miss S is a 71-year-old woman with a history of diabetes and hypertension. Recently widowed, she currently lives alone in her own home. She has one son and one daughter. She is brought into the clinic today by her son Dave, who reports that he and his sister are concerned about mom's memory. Miss S does not believe she has any significant memory problems. Yet, her son describes 2.5 years of progressive memory deficits characterized by increasing late fees while paying bills and difficulty maintaining the household. Over the past 3 months, the son has received repeated phone calls from his mother in which she complains repeatedly about losing items around the household. He reports that at one point she wondered whether somebody was stealing her keys and hiding her reading glasses. Originally, the son suspected that his mother was fixated on this topic, but over time, it became clear that she had forgotten about their previous conversations. Her cognitive review of systems is remarkable for forgetting appointments and becoming lost while driving in familiar neighborhoods. The son mentions that he is worried about his mom's driving as well. Miss S denied any specific symptoms for depression. Medications currently include lisinopril, 10 milligrams twice daily, ECASA 81 milligrams daily, and metformin 500 milligram with meals. Calcium and vitamin D daily, MOV daily, and Lipitor 50 milligrams every night. She reports needing to take Tylenol PM at bedtime in order to get a full night's sleep. The primary provider is hoping that simplifying the medication regimen will make it easier for Miss S to follow instructions accurately. Miss S is a retired school teacher with a college education. Miss S denies a history of smoking, but admits to drinking 1 to 2 glasses of wine every day. There's a family history of Alzheimer's disease in her father, who reportedly developed symptoms in his 80s. Neurological exam was non-focal. Neuropsych screening showed a MoCA of 21. Laboratory studies showed normal complete blood count, electrolytes, LFTs, glucose, thyroid stimulating hormone, and B12 levels. A referral was made for neuropsych testing. Miss S showed severe deficits in learning and memory, moderate deficits in visual spatial function, and mild executive impairments. The GDS score was 2 and within normal limits. Brain MRI was positive for bilateral hippocampal and parietal atrophy, but no evidence for stroke or focal lesions. Miss S was diagnosed by her primary provider, you guys, with probable AD. Her son inquired about any interventions that can possibly slow or treat the disease process. It is clear that the son is distressed about his mother's new diagnosis. He has many questions about his mother's safety and how he and his sister can proactively take steps to ensure their mother's future well-being. Miss S is started on donepezil 5 milligrams daily at bedtime for 1 month and is advised to increase that dose to 10 milligrams daily thereafter. Additionally, Miss S is started on trazodone 50 milligrams at bedtime for sleep. The follow-up visit is in 3 months. So the social worker then did a follow-up assessment and provided the note to the physician, and the significant findings were as such.
So here is your written copy. Okay.
Significant findings were that patient stopped taking trazodone shortly after initiated. She complained of feeling drugged. Patient also stopped taking donepezil after 2-week course, complaining of lower GI distress. Patient resumed Tylenol PM for sleep, and driving ability may be impaired. Patient didn't report any concerns, but the son reported concerns about understanding dementia diagnosis, helping with the patient's his mother's finances, help motivating the patient to socialize and increase activity level, in need of general support as a caregiver. Patient remains non-social, unable to complete IADLs fully, and generally sleeps off and on all day. Patient occasionally goes out grocery shopping alone, via car. The son reports damage to the vehicle, and patient does not know how damage occurred. The caregiver is the power of attorney, and they did not follow up with the Alzheimer's Association. The recommendations that the social worker made was to follow up with the Alzheimer's Association for caregiver support services, and the social worker provided in-depth information on caregiver support groups, adult daycare programs, and local resources for companion care to address caregiver concerns and need for assistance with caregiving. So what we're going to do now, before we turn this off, is we're going to separate you two into two categories. One is concerns based on that follow-up assessment, the social worker follow-up assessment, your concerns regarding pharmacological aspects. The second person is going to be working on non-pharmacological / safety concerns regarding Miss S. So one of us is going to take you into a different room regarding pharmacological, and then the other one is going to take you into the room regarding non-pharmacological and or safety concerns. After that, we're going to reconvene in here, and we're going to do the role play. All right? So
A little bit about how that will go.